this is the trabecular system of the acetabulum. This is the trabecular of the head of the femur, and to some extent there could be a deviation in the head and neck, to some extent only. But what is likely to happen in type 2? In type 2 system, all the three systems are going to be clearly aligned. There will be a complete alignment in type 2 because the fracture is complete, but it is having no displacement at all. What is likely to be seen in type 3? What happens if there is a fracture which is of type 3, where there is a fracture and it is having to some extent the alignment is present in between the two, means to some extent both of them are related to each other. So what is likely to happen, or what is likely to be seen, that if this is the acetabular trabecular alignment, because of the impaction of the displaced fragment, there will be a change in the alignment of the head of the femur, and there will be a change in the alignment of the neck of femur. So all the three alignment of the trabeculae are going to be disturbed. This is not in relation with the head, and the head trabeculae is not in relation with the neck. This is how everything is changed in type 3. Alright, but what will happen in type 4? In type 4, when there is a complete displacement, then the head of the femur will be rotated back to its normal position. The head of the femur will be derotated because it is not having any influence of impaction by the distal fragment. So the trabeculae of the acetabulum and the trabeculae of the head of the femur are normally aligned, but the trabeculae of the neck of femur is going to be disturbed. So this is likely to be seen in type 4. Alright, so this is the X-ray appearances of the Gardner's classification. As I told you, Gardner classification can be identified based on two aspects. One is theoretical aspects and the second one is practical aspect. So this is the X-ray identification of the trabecular alignment. Now if you look back to it again very quickly, that this is type 1. Because of some valgus impaction, there is likely to happen some disturbance in between the neck and the head of the femur alignment of the trabeculae. But all the three trabeculae will be completely aligned in type 2, because in type 2 there is a complete fracture but there is no displacement. In type 3 there will be a complete misalignment, means all the three fragments or all the three trabeculae will be completely misaligned or de-aligned to each other in type 3, while in type 4 the acetabular and head of the femur trabeculae is or will be aligned, but there will be misalignment or de-alignment of the trabecular arrangement in head of femur and neck of femur. This will be de-aligned. Alright. So if at all the examiner decides to put this question in your examination, it will be provided in the form of the X-rays or in the form of a diagrammatic representation, and then they will ask what it is, whether it is type 1, 2, 3 or 4. That is what the essence of the Gardner's classification is. Now comes the management part or the treatment part. As far as the treatment of this fractured neck of femur is concerned, before we talk anything related to the treatment, it is important to have a discussion on the age and the impact of the age in the management. Alright, you know the clinical features for the fractured neck of femur. First of all, it is the fracture which will happen in elderly. So more likely this is the fracture which is seen more commonly in elderly individuals. You know, females are far more commonly affected compared to males, and the reason which is attributed to this more common affection in case of females is because of osteoporosis. Alright, primary senile osteoporosis, which is the more common reason for this fractured neck of femur encountered in case of females. The attitude, that means how will you identify that the patient possibly is suffering from the fractured neck of femur? That there will be external rotation. So the limb which is affected by fractured neck of femur will be externally rotated, but that external rotation is not going to be up to an extent of 90 degree. This external rotation may be around 60 to 70 degrees of external rotation, along with flexion of the hip joint, because if the event is acute, the event would be painful. In order to limit this, there will be slight amount of flexion also. So this is how the patient will come to you on couch. Imagine a 65-70-year-old female coming to you on couch, lying on couch, right sided foot is normally externally rotated up to 10 to 15 degree and it is kept in extension, while the left sided is kept in slight amount of flexion or is held in complete flexion, but the foot is kept in 60 degree of external rotation. Then at that moment itself you will make the diagnosis that possibly the patient is suffering from fractured neck of femur. Now comes the management. Management is basically, or the treatment is basically, or could be divided into two. One is fixation and the second one is replacement. As far as treatment is concerned, one is fixation and the second one is replacement. So before we talk anything related to this fixation and replacement, let's have a discussion on what do you mean by the term fixation and what is replacement. That means what is osteosynthesis? Means fixation means osteosynthesis, where you will try to unite the fractured fragment. Replacement means replace it with the prosthesis. So what do you mean by the term fixation and replacement? Just try to understand. Now the patient had a fractured neck of femur and this fractured neck of femur is fixed by the placement of this cannulated cancellous screw, CCS. So here you are trying to save the head of the femur and the neck of the femur, trying to achieve the union at the fracture site by saving the head and neck of the patient. Alright. On the other hand, if there is a fractured neck of femur over here, now what you have done, you have removed the head as well as neck and you have placed a prosthesis inside. Alright. So that is replacement. You have replaced that head as well as neck region. Alright. So fixation and replacement. Osteosynthesis. Let's have a discussion on the fixation and replacement now. As I told you, the management could be achieved by fixation and replacement. Now, what are the indications for fixation? The indication is that if the age is less than 50 years, if the age is around 50 to 60 or less than 50, then possibly, first of all, you have to go with the fixation. You have to decide for the fixation. All right. And the another indication is that there is no associated comorbidities. All right. On the other hand, the indication for replacement, here you are performing the replacement. So the indication for replacement is that obviously if the age of the patient is more than 60 years of age, so it is an absolute indication. Don't go in between 50 and 60 because no question is going to be asked related to that. But yes, if the patient is having an age group of, for example, 55 years and he's having diabetes mellitus also, chest infections also, decubitus ulcers also, all right. So if these are the debilitating condition the patient is presenting with, in that case, replacement is a better option. So indications are more than 60 years or if there is an associated comorbidity like diabetes mellitus, hypertension, apart from this chest infections, all right, then recurrent ulcers. So all these are considered to be the associated comorbidities which requires replacement as a primary mode of management. Now comes the question is that why diabetic mellitus patient should be treated by replacement, not by osteosynthesis. The reason is that in case of diabetes mellitus, the patient need to walk in order to limit the morbidity associated with the disease. And if you fix the joint or if you fix the fracture, then you have to wait. You make the patient bedridden for some duration of time. Then when the walking is allowed, then the patient cannot walk on the affected limb by putting the weight on the affected limb. It has to be delayed for some duration of time because you have to achieve union without any displacement at the fracture. Second, in case if you have performed a replacement, you can make the patient bear weight on the affected limb next day after surgery. All right. Today you have performed the surgery, next day you will ask the patient to bear weight on the affected limb and start walking. Thereby you can limit the progression of the disease and you can limit the hazards associated with that disease because of non-ambulation. So hopefully you have understood how it has been classified or categorized. So it all will be dependent upon the question itself. Like if they give you an age group of 57, for example, which is lying in between 50 and 60, they have to give the associated comorbidity in the question if you have to mark the answer related with the replacement. All right. But the replacement is actually of two types. that was the fixation, osteosynthesis. You need not to go into the details of the implants which are involved in the osteosynthesis. Just remember, osteosynthesis, that means fixation. Now, the replacement actually is of two types. One is hemiarthroplasty and the other one is complete or the total arthroplasty. So this replacement actually is of two types. Or the replacement surgery could be of two types in the fractured neck of femur. One is hemiarthroplasty and the total hip arthroplasty. All right, total hip replacement or total hip arthroplasty. Now, in hemiarthroplasty, what you are doing, you are just removing the fractured head as well as neck and then replacing it with the prosthesis. So, hemiarthroplasty prosthesis can be of two types. You know, the prosthesis which are involved in hemiarthroplasty can be of two types. One is a unipolar prosthesis and the other one is bipolar prosthesis. So first of all, try to understand what is the difference in between total hip arthroplasty and hemiarthroplasty. You know, in hemiarthroplasty, what you are doing, only the fractured head as well as neck is removed and is replaced by placement of the prosthesis. So this is one such prosthesis. All right. You are not covering the acetabulum by any other implant. In case of total hip replacement or arthroplasty, what you do, you are not only removing the head as well as neck, but you are also curating, you are also preparing the acetabulum, and the acetabular cup is fitted onto the or is fixed onto the acetabular cavity. So you are creating an implant or articular surface on the acetabulum also, as well as for the head of the femur also. So that is total hip arthroplasty. That is the difference in between the two. You know, the prosthesis for achieving this hemiarthroplasty are of two types. One is unipolar, other one is bipolar. So how to identify unipolar? Unipolar means one head, all right, single head of the prosthesis. Bipolar means although it is a shell and inside that shell there is a placement of the head. So it will be a shell plus head of the prosthesis. All right. Now, unipolar are further categorized into two types. There are two types of unipolar prosthesis. One is Thompson's and the other one is Austin-Moore. All right. Now, under the heading of Thompson's, how will you identify a Thompson prosthesis? In Thompson prosthesis, there will be a eye in collar, while, there will be no eye in collar in case of Thompson, while there will be a presence of eye in the collar of the implant in case of Austin-Moore. So all these things you will come to know when we will talk about the images. So first thing, before we talk about these specific images of the prosthesis, it is important for you to distinguish in between osteosynthesis, that means fixation, that means achieving the union at the fracture site, and the replacement means removal, and you are replacing it with the implant, you are replacing it with the internal prosthesis. Now the placement of the prosthesis can be of two types. One is total hip arthroplasty, where you are providing the acetabular cup also, means both the articular surfaces are prepared by an artificial implant. Hemiarthroplasty is acetabulum is not touched, it is only the head as well as neck which is removed. All right. So that is hemiarthroplasty. Hemiarthroplasty related implants are of two types. One is unipolar and bipolar. Now, in the unipolar implant, there will be a single head. As you can see, this is a single head, unipolar. Here, there is a single head, unipolar. But if there is a shell and inside that shell, there is a presence of the head, that means it is bipolar. So here we are visualizing a bipolar prosthesis and both of them are unipolar prosthesis. Now, these unipolar are further categorized into Thompson and Austin-Moore. Now, if you look at the parts of the prosthesis, if you see, this is the head of the prosthesis, this is the collar of the prosthesis, and this is the stem of the prosthesis. All right. So, what is the difference which is achieved in the collar of the prosthesis or is visualized in the collar of the prosthesis is that there is no eye in this collar, but there is a presence of eye in Austin-Moore. That means there is a hole which is present in the Austin-Moore. Although the reason for this placement of the hole is